All right. Well, thank you for inviting us to share our presentation. It's going to be a modified version, but all of the resources that we developed you'll also get those in the back. And Sean said hello, and Sean and I are probably about the same when it comes to doing introductions. So we are shy people, and so we don't like talking about ourselves. So we'll just leave it at that. So what we did at the conference is we actually had a little bit longer period of time, but we covered these particular areas. And so we're going to cover the first part of that area, and time permitting, we're going to show you a quick video on stigma, and then open it up for any questions that you might have. So there's a general overview and then some specific things. And one of the things that we want to invite all of you to offer as part of our presentation as we discuss it is any cultural practices that you found to be very helpful that might fit in with this definition of harm reduction. And Sean, I can't see your face, but I know that Sean often contributes in the chat box, so we'll look for those comments, and then I'll pass it over. We'll kind of go back and forth if that's acceptable, if that'll work for you. Okay. So harm reduction defined is, and again, we're trying to present harm reduction in a culturally sensitive manner, and we feel and believe that it's very, very much, and just in the principles of harm reduction, encourages that view. And in its development, it came out of a compassionate development for looking at people and their struggles in life, and so it's inviting us to look at life within all peoples in a good way versus in a shaming or stigmatizing manner. And the primary goal of in any kind of harm reduction approach is to look at the high-risk behaviors that are affecting individuals, families, communities, and services that result in a bad outcome for all of those, all the people. The norms and values and traditions within various tribal communities are also emphasizing, and all of you know this, more of a holistic view. So we want to look at a harm reduction more than just a medication-assisted treatment program, but more towards individuals, communities, organizations, families, etc. With that said, and I'll ask Sean to add some thoughts. We're looking at helping people with mental health and substance abuse issues to respond to them in a compassionate way. And I highlighted this statement: we honor our traditions of sharing what we know, helping others, and respecting all life. And I know that a lot of the TOR folks have run into some struggles within certain areas regarding stigma and rejection of tribal members. And I think the point of this site is really to remind us that that in our spirituality, that's it goes against our spirituality when we don't respect the struggles of people, and through our particular skill set, help them to heal. Okay. Any thoughts, Sean, you want to share? I don't want to over speak. Um, let's see, I've got this weird thing that's blocking some of my, oh, okay, maybe I could, there we go. All right, harm reduction recognizes the realities of poverty, class, racism, etc., trauma, particularly, and other injustices, and vulnerabilities of people. Harm reduction approaches address the problems. They don't minimize, ignore, or reject the problem. They look at it from more of a, okay, how do we help people get out of harm and dangerous behaviors and thoughts so that they can heal. Okay. And a little bit about the history of harm reduction. The latest, this is a kind of a living, the idea of harm reduction is a living concept, meaning that it has evolved since its first introduction back in the 80s, 1980s. But really where it came from was out of a public health concern or policy in Western Europe, because they were experiencing in I believe the Amsterdam, an uptick of epidemic of hepatitis and HIV/AIDS. And so that's where the original idea of harm reduction started, but it certainly has grown way beyond that at this point, where you were doing needle exchange programs to reduce the incidence of hepatitis and HIV/AIDS. And that was back in the probably the late 70s, early 80s, when that it was basically Dr. Marlatt, who is now not with us, and his colleagues at the University of Washington as a researcher brought it over to the United States to help with the drug use issues and the same HIV and hepatitis epidemics happening in this country. So it's kind of gotten a bad name in some respects because people don't understand. They really don't understand that it is very culturally sensitive if we are following the spiritual practices within the tribal communities. So we broke this down into these 4 different areas. And I don't want to do all the talking, Sean, so you're going to have to come in. I hate hearing myself talk all the time. And I don't know if you're here, if you wanted to cover this one. I will if you're not here. I don't see Sean. Did he go somewhere?
It looks like we might have lost him.
Okay. Well, then I won't worry. I won't worry about it.
About doing all the talking.
Well, yeah. Feel free for anybody to speak up, but I wanted to include Sean as much as possible. But if he's having internet issues, then I'll proceed. So when you look at the historical context for harm reduction principles and practices for substance abuse, I just mentioned the HIV needle exchange programs. For mental health, the use of medication management coupled with both cultural and Western medicines to address trauma, anxiety, depression, and other mental health conditions. For physical health, keeping up with preventive care, blood sugar, heart, lungs, diabetes management for blood sugar levels, encouraging diet and exercise. And then for spiritual or spirit, to help people to re-engage, because a lot of the trauma reactions that hurt people, they've lost their spiritual way. And so it's helping them to develop healthy spiritual practices to enhance their overall well-being. So what we did in this slide is basically broke it down in if your tribal community uses a medicine wheel, we broke it down into the 4 directions to some extent, just to highlight how you could look at this. And these are things that people have already done. It's not new information, but if you think about harm reduction from for directions or healthy practices, depending on your tribe, that's one way to look at it. I think though, the one area where you get the most resistance is this substance abuse one, particularly because of the damage it causes within relationships. Okay, we got Sean back. Hello, Sean. Do you want to cover the next few slides?
Yeah, I can probably do that.
Okay.
Yeah, so it's part of harm reduction where the way it had come from, and reducing harm. A lot of times it gave people a choice, and that choice it helped people to make a better decision for themselves. But a lot of times in educating them, the dangers and harms that substances can do and things like that. But also it's like also looking at let's say what substances and things like that actually do to like the brain and things like that, neurotransmitters, the way it changes things. And because really the brain just wants to be kind of normal. It just wants a normal line going across, but with substances, they tend to peak one up, but by the time they come down, the brain is adjusting, so it kind of comes lower than what is normal. A lot of times when we see people coming into treatment, they might have been affected by the substances and the neurotransmitters and the changes, and a lot of times it's like you have receptor sites and stuff that kind of can close off after some time, but with abstinence, they say they can open up later on. But by the time we see them, they're a lot of times maybe going through depression, anxiety, things like that. So part of that we need to look at and looking at how to reduce harm. A lot of times, maybe a newer counselors or something like that want people to immediately be back to where everybody else is, kind of that activity and functioning that they are capable of. Maybe they're having a hard time staying awake or having a hard time with anxiety at the time, but a lot of times we need to be able to take that into account. And a lot of times what research and things like that is saying, by the time people are done with like a 30-day treatment, they're just starting to get better. And we need to be able to look at that and our clientele. And we always were told it's like start where they are from. And that's something we need to remember. And that'll help to reduce harm. And for us to realize that they're not going to be better immediately. Looking at like marijuana, I know in the past it said that it takes 6 months to a year for the brain and neurotransmitters to get kind of back to normal. For methamphetamine, some had said a year to 2 years. Some have even said longer, 714 or something like that. But there are many different changes that are going on, and it takes a while for those to get back to normal. So remembering that we need to be able to take that into consideration. And I know that when I used to work with clients a lot, in letting them see about change, and not just that, but also professionals. Like I might give them a paragraph of something that they have to copy, but I asked them to do it with their non-dominant hand. And I said, I want you to copy this down. I need to turn this into my supervisor or something like that. It's going to prove, or it's going to prove that I'm doing what I'm supposed to be doing. And I have them rush, maybe first I gave them 2 minutes, then I don't know, I was like, I need to do it right now. Maybe you got 1 minute. After a bit, I tell them, okay, we just need to hurry up and get this done. It's like, I don't care how you do it, just get it done. A lot of times people will actually go back to their dominant hand and finish writing that. And we need to be able to take a look at that, because we are kind of subjected to the same thing our clients are. When we're under stress, we go back to what we know works. And back then, the substances might have been helping them. But now that they're trying to get clean, we need to be able to take a look at change too. And that sometimes we rush these clients into getting everything, done, or making sure, or we think they're at the same capacity or functioning that everybody else is, but it's just not the case. Remember, change is hard, no matter if it's a good change. Okay, next slide. Okay, so harm reduction ensures substance users and those with a history of substance use routinely have a real voice. So sometimes when we're looking at our programs, looking at our treatment plans, they're part of that. Definitely a treatment plan. It's not just the worker. It's not just a counselor or therapist. They have to have a say. And a lot of times what helps sometimes is, like in the past, I used to give out kind of like little questionnaires throughout treatment, at the beginning, in the middle, in the end, and seeing what works, what they had thought helped, so that I could change that and help that to kind of adapt to each person. And over time, it seemed to help. A lot of times, and it's like we need to look at what is going to reduce our harms. Sometimes in the way that others may react to them also causes them harm. Like people maybe calling people drug users, or different names and things like that. A lot of times they might want to stay away. Well, that's also reducing. It's also harming them in some way. What the big thing is we need to be able to get them back into the community where they have that support. So it's very important that we empower them and to give them the tools that they need. Maybe reach out to people within the community that can help them and help them go beyond what maybe they were doing in the past. Because in our culture, a lot of times, if they were attending ceremonies and really going strong in the ceremonies or things like that, they start to use, and out of respect they come out of those. Well, a lot of times people who are used to see them at the ceremony say, hey, where you at? I haven't seen you for a while. What you been doing? When you coming back? A lot of times that brings some stress upon them. So what happens is they isolate a little bit even more. And next thing you know, it's like the community's asking, hey, where you been? And eventually it goes back to the family. And then finally they're kind of staying away from the family. But we need to be able to get them out of that isolation and let them know there are helping hands out there that can help them and guide them back. So, all right. Next slide. Okay, so different models we're going to be looking at. Next slide. Kathy?
Okay. So what Sean was talking about is that we titled this presentation Reimagine. So as we know about traditional Western-based harm reduction strategies, we're really asking you to think about it from a reimagined, culturally based perspective, and that's really what we're trying to invite some thinking around. So the models, some of you might be using these models, some of you might not. Some of you might not have thought about it. Some of them might work, some of them might not work. So we'll just, share these models with that kind of in mind. So moderation and controlled use strategies has been around for decades when it comes to substance abuse, particularly. For opioid and methadone programs, there used to be a belief that people should be abstinent no matter what. And they could have their methadone maintenance, they could have their Suboxone, buprenorphine, et cetera, as long as they agreed to be drug and alcohol free completely. So the idea of controlled use was in the several years ago, was like a new concept, and because we grow and we learn from each other and we learn from the people we try to serve, what we found was that not everybody was willing to be an abstinence only person. However, we could still reduce their harm by helping them to address what's causing them the most harm. And over time, often they'll lead themselves to the fact that other substances, although they may not be technically addicted to that substance, it may not be in their best interest. But it, it varies from person to person. So when it comes to needle exchange programs or doing behavior monitoring or tracking of someone's alcohol use, or taking medication assisted treatment, those are some examples of controlled use strategies in moderation. Controlled use often came out of an alcohol issue in the sense that if a person wasn't wanting to label themselves and they really thought they could control their use, then the behavioral approach was, well, let's see if you can, and let's just monitor it and see what happens. And for those people that were affected at the brain level, they found that it was very hard to moderate their use. And for those who could moderate their use, you basically created an opportunity for them to stop the harm that was coming their way. Needle exchange, we've talked about that. Damp housing. Now that's an example of not completely abstinence. We're not going to deny you housing if you're not completely abstinent, but it depending on the program policies will allow you to stay as long as you are working a program, and we acknowledge that you may have some relapses, or will allow you to stay here as long as you don't use in the house or the campus or wherever. And that's particularly helpful for people with dual diagnosis issues, because it's hard to do everything all at once. And it's just acknowledging a process that people go through as they start to heal and start to reconnect to a healthy side of the culture and the people that are willing to help them. We talked a little bit about substitution therapy. I think most of you are pretty familiar with this. Some of you are providing that. I keep seeing that warm turkey. Nick, do you want to talk about that, Sean? It's kind of a funny term, warm turkey. But because there's nicotine in some cultural and spiritual practices, I think it'd be important to discuss that. So I'll turn it over to you, Sean.
Okay. Yeah, I mean, in looking at the warm turkey, in a sense, like let's say, for instance, somebody used to smoke cigarettes. Well, they're reducing the harm is getting rid of the tobacco, and part of that is also, cigarette tobacco, commercial tobacco has a lot of different chemicals in there, things like that. But also in burning, the process of burning also releases carcinogens. So when people are smoking or anything like that, that burning part of it is going into themselves. But just taking nicotine is reducing the harm of that by giving them nicotine and not giving them these carcinogens that are part of the burning process and in commercialized tobacco. Patches and nicotine, well, the patches kind of work the same way. The chewing gum, a lot of times I think people need to be able to look at each one and maybe even try it if they want to stop smoking. to see which one works for them, because sometimes the patches might cause some irritation. The gum or nicotine, like tablets or something like that, might also cause some kind of discomfort in the mouth. So trying different ones might benefit them, and see which one works for them. I think right now the IHS and the clinics like that can provide nicotine packages, but not the others.
And I think that with nicotine in the spiritual practices, it's, you have to be aware of triggers, right? But it doesn't mean you can't be involved in a spiritual practice that involves nicotine, because it's like you're saying, it's not the same. It's not like
Yeah.
over the counter.
Yeah, a
Yeah.
lot of times it's like, I think when we're looking at traditional use of tobacco or the use of traditional tobaccos, a lot of times we're looking at commercialized tobacco, whether it's being smoked or being used to pray with. And a lot of times they might make prayer ties, prayer flags, different things like that, offerings, whether it depends on different parts of the United States too, because each different tribal area does things a little bit different. It's like down in the Southwest, I might use pollen. In some of the areas like Wisconsin, Minnesota, Michigan, things like that, they might use what is called kinnikinnick, and it's a different part of different plants that's put into there. And a lot of times it's like mullein. And mullein can be used in substances like that because it's actually medicine to be able to help certain things. But like in the Great Plains area, a lot of times they use what is called chanchasha, and that's a different part of another plant that they use within there. But it's not always used for smoking. And what I was always told, like people like pipe carriers, medicine men, and stuff like that, they're not always inhaling these things. What they're doing is bringing it into their mouth and blowing it out, because the smoke is not necessarily for them; it's for the spirits.
Yeah. Thank you for that. Okay. Relapse prevention. There's a whole other conversation we could have about relapse prevention. There's very specific models of relapse prevention, and it's really cognitive behavioral in its nature, those particular Western-based models. But basically, it relapse prevention as defined by having a period of recovery. So there's been time of being in recovery, and the relapse is you relapse back to old behaviors and old patterns. So a harm reduction approach to relapse prevention involves reaffirming somebody's commitment to want to be in recovery. It's a kind of a misunderstood concept because people in the general population look at it differently, but essentially that's more of the traditional model of relapse prevention. And in the Western way, it's a very cognitive behavioral approach. So you break down, where were you, people, situations, your emotions, what happened specifically in those different, when you relapsed, what was going on, what happened just before you relapsed, were you aware cognitively of your behavior and your patterns, were you open to feedback from other people, what were the cues, what were the and so this is very, walking somebody through to help them understand where they are more at risk, and people, places, and situations. So now some people, there's the 12-step program calls it HALT. So a simple way to look at this is you never get too hungry, angry, lonely, or tired. And so that idea of how am I taking care of my mental well-being? How am I taking care of my physical well-being? How am I taking care of my spiritual health and well-being? Am I processing and taking care of my emotions? So again, you can use a cultural overlay to that, but essentially is where am I out of balance? And am I aware that I'm out of balance? And who are the people that I'm listening to? And are they people that have my best interest at heart? Or are they people that are struggling like I am? So all of that goes into the traditional and the cultural perspective about relapse prevention.
Yeah, if I was thought relapse prevention is one of the kind of things you really want to stress within treatment. Once you get them to that point, it's, we really need to be able to keep them clean. And
Mhm.
it's an area that you can really help to stabilize them and to strengthen them and to give them things and tools that they could utilize to help in prevention. A lot of times what I always say is like with many people who utilizing like the medicine wheel as a treatment perspective and stuff like that, is that many times they don't pay enough attention to the emotional part of the medicine wheel. And this is where it really kind of ties in, because a lot of times people react out of their emotions, their harms, their hurts, and all these things that they've gone through all their years. Because when we look at a lot of times, it's like a lot of people who have used substances also have some kind of trauma in their past.
Mhm.
And a lot of times they'll look at that as substance use is more of part of that. It's part of the underlying things where we're looking at and treating this trauma and pain, internal pain that's happened before. And and a lot of times, what I always ask kids, people, whatever, is like, how many here has ever been taught how to deal with difficult thoughts, feelings, and emotions? A lot of times it's the same story as parents and people tell us, oh, it'll get better, just ignore them. But each kind of generation, we're doing the same thing over and over again, relearning this while I've kind of take it upon myself, even work with youth and stuff in the past, is to help them in looking at different things, how to overcome emotions, how to overcome difficult emotions, because a lot of times we need to look at that and helping them to overcome anger, fear, shame, guilt, a lot of these things like that, that is kind of influencing their life. And when people are going through are about to maybe relapse, it's something that they need to strengthen during that time and give them the tools to go beyond that, to say no or something else, find something else to keep themselves busy for 15 to 20 minutes, because they say um, it's that craving's only going to last about 15-20 minutes. If they can get by that, it'll help them.
There's a practice that I think is very culturally sensitive. Is called self-compassion. And sorry about the dog, but he's going to bark. That's what dogs do. Anyway, it's Dr. Kristen Neff, and I did some study with her, and basically she's saying that's exactly what she says, is like you learn how to become more resilient when it comes to your emotional well-being, and that emotions come and go. It's a fluid thing, and they get rigid when we try to pretend they're not there, and we try to not deal with them, and that's where they stick around. But if we just accept, which is, I think, from a spiritual perspective, if we just accept that they're there and it's a flow of life and they come and go and they don't stick around forever, and this too shall pass, it's much easier to develop more resiliency I had a close friend who recently told me, and I thought it was an interesting thing. He said, I was trying to take care of myself. He was relapsing, and he was relapsing in a bad way. And everybody was worried about him. And I said, well, it sounds like you were trying to take care of everybody but yourself. And he says to me, and some people who are recovering will understand this, I'm sure, and others. He said, well, I was taking care of myself. What meaning that I didn't have the skills to manage those difficult emotions. And so the way I took care of it was to use. And I thought, oh, that makes a lot of sense to me. And then he said, but what I realized is that's not the best way. And I thought that was a really important insight from a recovering person when it came to relapse and his difficulty sustaining a healthy recovery program over time. That's why a lot of programs, whether outpatient, inpatient, in a medical setting, address relapse prevention is to let people know that the recovery gives you time to build resiliency, to have compassion, to understand and learn that emotional pain doesn't stay forever unless we make it stay. That's piggybacking on what you said, Sean, but I think this is an important one to understand from a harm reduction perspective, that even when people are relapsing or even when people continue to use, it's important not to give up on them. It's just they don't have, they're doing the best they can. They're taking care of their pain the only way they know how in that moment. And you have to trust them that they'll figure out that's not the only way. There are multiple ways to help them with their pain that doesn't involve hurting themselves or others. I think this is the final model. Yeah. So a lot of you are probably doing this, just raising the awareness. I've had several conversations with different tribal communities in the last month about this, that their frustration with the community not accepting harm reduction as an approach, and what can we do to help people understand that this is valid, it's important, it's a way to begin to address things. So if you can't get what you really want, like say, as an example, a community believes that, oh, you're just replacing one substance for another, and people can't get past that. Then, using a harm reduction educational model might be your first step to raise the awareness about what is really going on. I think, and that people don't have control as much as they think they do, and that they're not purposefully trying to hurt the community or their family or themselves because of what Sean said earlier about how the brain's working and it's not working. So using a harm reduction approach with education, more of a entry level into helping tribal councils, family members, or agencies and organizations, and the community at large understand what people are going through and understand the nature of drug-related harm. So let me see how we're doing on time. We have just enough time to talk a little bit about this, and I'm going to pass this on to Sean, and then we'll show a short video and call it good.
Okay, this is something I've always thought, that working with natives is very important to learn. I mean, if especially like a lot of natives have been through a lot of trauma, a lot of different things in their life, prejudices and things like that. And a lot of us have really learned to pay attention to small cues, little bitty eye movements, little bitty face movements, the body movements and everything like that. And I think it's kind of something like, maybe a survival kind of thing that we've learned, and paying attention to a lot of this. And it's something we need to look at more, I think, when we're working with certain populations, because they may go through the same thing. I do know, working with teens who are teenagers who've gone through a lot of problems in their life, whether they've had abuse issues in the home or something like that. And I've seen how just small little movements can really trigger them, and that they can become very, either more weary, they become more defensive, things like that, because of what they're used to and what they've learned growing up. And of course, a lot of times they may keep these when they're, get older, but little bitty things. I mean, um, a lot of times they look at that and they catch on very quickly. So it's something I've really paid attention to. And it's something like just looking at microaggressions. I mean, there are dismissive looks somebody might give. I mean, somebody else, they might not see it, but sometimes even the eyes might even be slower. I mean, it doesn't mean they're just going to turn away. Even though the eye itself doesn't really change, except for maybe the pupil. It's like the eyes around there kind of change a little bit. So maybe they feel that they see like an intimidating eye contact or something like that. But a lot of times, Native Americans don't always give you eye contact anyway. It's just part of the culture. So a lot of times when we're working with people outside our culture, they think we're not paying attention, but you can pretty much guarantee they're paying attention to everything going on in the room. It's whether they're drawing or doing something else, they are paying attention. So looking at even just our little comments, even just little bitty things, I mean, it can really trigger them. Looking at demeaning communication, they might see it as rude, and remembering that the culture might be different too, and they can see things as more rude than others might. So just even like ignoring or invalidating somebody's experience, thoughts, beliefs, and affiliation, that can be very harmful. But we need to be able to look at their point of view, and to be able to see those better, and to sometimes we need to be able to picture ourselves going through that, to imagine what it really feels like.
I kind of think of this as an assault on the spirit. It's an assault on the person's spirit and soul. And I think all of us has probably experienced many of these, or some of these at least, over the course of our life. And the other thing too is you notice how it happens to the people we're trying to help too. So not only do we experience it, but we are present when our clients or the people we're trying to help experience it. So it's a double whammy for us, especially if you happen to be a very empathic person. And you can feel those arrows coming at you in the slaps and the invalidation, particularly with opioid use. It's very common, and there's like a hierarchy. So if you happen to go to a 12-step meeting that's alcohol related, and somebody with Suboxone walks in who's trying to get into recovery, and that's the only meeting available, you might get some of these type of experiences. It's not consistent with the traditions of the 12-step program, but it does happen. So it's important as part of an educational approach to help people understand this, and to call upon their humanity and their compassion. Okay. We're just going to take a brief moment and show you a video we found. I believe Sam's up here created. There's a series of videos that this woman shares, and we have all the other videos in the resource section we can give you later, but we wanted to show this one I hope this works. I think I have to turn on sound. Hold on. Let me go back to screen share and do sound.
And optimize for video clip.
Okay, thank you. Okay, I hope this works.
When we train housing providers and other providers on harm reduction, three things that we like to get across. One is from Pat Denning, who was a co-writer of Practicing Harm Reduction Psychotherapy. It's a great book. And she talks about substance users, and she says, people with substance use disorders are people with problems, not problem people. And I think that that's a really nice, concise statement that gets at the stigma that's associated with people with substance use disorders. That they're difficult to work with, that they're liars. I often hear that. That you can't trust what they're saying, that they don't care about themselves or anybody else. They're thieves, they're this or that. People don't want to work with them. They've been volleyed between mental health and substance use systems for a long time. So we really try to humanize substance users and help people understand that like any other disorder, these are human beings, really creative, resourceful human beings that have some problems, not problem people. Another thing that we try and get across is that people who use drugs make healthy decisions all the time. They can and do make choices about their health that are pro-healthy, that are pro-social decisions as well. They take care of one another, particularly opioid users, really take good care of one another. For example, when somebody is dope sick and doesn't have access to the substance to get right, people often share what they do have. People take good care of one another. And so recognizing that and understanding that and affirming that in people when people are working with folks with substance use disorders, that's something that we try and get across. And then finally, that there's a lot that you can do to help people short of total radical abstinence. So something I often hear from people is, if they're not ready to stop using drugs, there's just not much we can do. So we do a substance use management training to help people understand the biopsychosocial phenomenon of drug use. So it's not just about the drug, right? It's not the presence or absence of this drug use, but there's the biological piece, there's the psychological piece, and then there's the social aspect. And people can make really tiny, subtle changes in each of these areas that can have huge impacts on their quality of life. And I find that it's really heartening for people engaged in this work because people tend to get disheartened. They tend to feel at a loss with some folks and like there isn't anything they can do. And it feels good to know, oh, there is actually a lot I can do with this person, even when they're engaged in pretty significantly chaotic substance use patterns. We can help them unpack that. We can help them figure out little things they can do, like using a clean needle every time, like making sure somebody else is with them when they use, like going to the doctor on a regular basis, treating their abscesses, preventing their abscesses, so on and so forth. There's many tiny incremental changes that people can engage in.
Mhm. Okay. We have some resources we can share with you. I think Meg will be sending out that. Yeah. Right, Meg?
I'm looking for the link now. Yes.
Oh, well, I've got the link in the PowerPoint
Okay.
for that and a couple other videos. But I think that kind of sums up with the time that we have. Any final comments, Sean? Before we go to Q&A?
I don't know. I think a lot of times it's like if you ever been through like the OWI program or DUI program for helping people get their license back, I think a lot of times they look at state dependent learning And a lot of times it's like people utilize, they're learning things while they're in a certain state, but a lot of times it's like maybe there are those who are really, really shy, and they learn that they more outspoken and feel more comfortable when they use. But that is kind of like something that they realize later on, that they're kind of using that as a crutch. And when we look at it, we could see them as their this is kind of something that could cause problems later. But in some ways it's giving them some kind of positive reward, which helps them to reinforce that. And when we're looking at these things, it's like what I was talking about, change before. That's something also that we're going to be kind of fighting against. So sometimes even in harm reduction, we're looking at not just total non-use, but they do have low drinking guidelines and things like that that are supposed to be a little more healthier, but at the same time it keeps them out of certain harm. And I think the biggest thing is, like, as a counselor, as somebody who's working with clients, our biggest thing is to keep them alive. And I think that's something we need to be able to look at, and not just total abstinence. Because you look at some people, they go totally abstinent and they're having issues because that drastic change right away. I mean, especially if they're not on some kind of medication assisted therapy or something like that, they're going to be having these other kind of like negative kind of feelings and thoughts and everything else like that. We're looking at withdrawal symptoms, and a lot of times that might be more uncomfortable at times for them than anything else. So working with them a little slower and helping them get back to abstinence through like harm reduction, and I think that is a pretty good goal. I think it.
Okay. So we just want to open it up for discussion and any questions or comments that you have. Hi, Robin. Nice to see you. Yeah. Yeah, there's a series of videos that we'll send out to you, along with some other resources that we shared at the conference in a couple weeks ago now. And that was pretty well received from people. But what are some questions or thoughts that you would like to share at this point before we go in to a break? Feel free to use the chat box too. You don't have to say if you don't want to speak.
I just had an observation with when you were talking about the resistance of the community and perhaps families to the idea of medication-assisted treatment. You remember in one of our meetings recently, someone said that they've rephrased that, the replacing one drug for another, to this is medicine. This is medicine to help the person recover from their addiction. And that framing struck me as really important to help fight the stigma that the community might feel about medication-assisted treatment, or place things like safe injection sites and that kind of thing.
Yeah, I remember that. Part of a harm reduction prevention program would be that, is to reframe MAT to here's a person with opioid use who's having trouble stopping. And one of the educational things you could do is, so how do we help them in the physical way, is we provide them with medicine. And here are the medicines that we know are helpful. So that's how you would reframe it, as opposed to, oh, they're getting drugs and it's just one drug for another. And then you can go more into the brain stuff as well. Yeah, addiction is a disease, like diabetes, high blood pressure. You take a medication for those things, and addiction is the same way: chronic, relapsing, progressive disease. And so reframing the conversation. I thought that was very helpful, actually, when I heard that.
Brandy had her hand raised earlier.
Brandy? Yeah, Brandy, you said causes most relapse, or ... cause for most relapse. Can you expand on that a little bit if you're there? Where are
Yeah,
you?
that's when you were talking about not the stigma, but the people being judged by being in the program, the discrimination of being a drug user or have a history of drug use. I felt that, and I hear, from people we help is, well, I heard this or so-and-so, kind of just like re-slamming the door on them and them feeling at their wit's end and pushing them to use. That's where that comment came from. But so I had my hand raised because it's the MAT program down here in our community is pretty new, and thankfully we work with the doctors. We're able to advertise now as this medication is it's not a replacement for another drug. It is a medication, like Sean was saying, for diabetes, heart disease, the same thing people take regular medications on for. And so treating it as, because drug abuse disorder are anyways, all the acronyms that we have. My brain just went blank.
Don't worry about it. Don't worry about it.
It's like letting them know that this is a disease and that if they had a choice, they wouldn't be doing that. So then educating them that this medication is just like a diabetic medication, just like a heart disease medication, and that just to help remove that stigma a little bit more, which has been great, especially with our new provider over here. But yes, thank you.
Yeah, this is something I actually used to use where I worked before. Is some people had some difficulty in wanting to use medication because they think it's, well, that's not our medicine, it's not real medicine. But reminding them that 70% or so of all medication derives from indigenous knowledge.
Being from a tribe,
yes.
Being from a tribe, that's where we come across it a lot. Oh, it's not traditional, or kind of that fear-based, they're on medication, don't really want to deal with them. And it's like getting them over the biggest stigma getting them to the history and knowledge of addiction medication, which goes back to, like Kathy said, the early 80s. And actually, by me speaking out, it made other people say, yeah, I've been taking medication for my alcohol abuse for 20 years. And it's like, wow, you know, if other people, if they're able to share their story with other people, I told them how beneficial that would be, not only to our community, but to this program. Because our whole mission is to reach as many, educate as many of families, be that safe outlet for them, for the person who's struggling, for the families that never gave up on them, and for our leadership. I would have to say our biggest hurdle is our leadership of them like this, you know, don't want to see, but then it's just slowly helping them, educating them, getting people to talk, share their stories. And it's actually, I told them, you know, we moved mountains before and it's time to move them again.
That's a nice analogy. I was thinking, some of you might be aware of this man, William White, wrote a book years ago. It's probably updated now, on the history of addiction in the United States. And it goes back to the 1700s, actually. One of the, and I'm going to put it in the chat here, the link to it. It's the history of addiction and treatment and recovery in America. I don't know if this is a good link. It's called Slaying the Dragon. But some of you might be interested in looking into that. It's a really nice book about where we get this stigma from. You know, where did it come from? How did it develop over centuries, really? Decades and hundreds of years. And he's an author and a scholar. Oh, you got it.
Can't really
There
see
it
it.
is. Yeah,
It's very
a
big.
great. It's actually big, but it's not like the DSM or anything like that. It's a storybook, really, about what we're talking about. So it's a great book to pick up because it's just about it's telling the story about addiction in the United States and the history of it. And in the 90s is when we discovered the brain science. It took us decades. It actually took us centuries to discover the brain aspect of addiction. And so it's just a really, second edition, there you go. It's just a really helpful resource when we're dealing with our tribal leadership. I've heard this more than once, that our tribal leaders are struggling with this idea. And so it's helpful. It's helpful to understand the history of this and I like that book because it's a storytelling book, basically. That's probably why I like it. It's not labeling as much, I don't think. Would you agree with that, Paul, or am I misrepresenting?
Yeah, I think it really kind of charts out the different kind of pathways of recovery that have evolved in this country. Like you say, going back well over 100 years now. And I just want to say, you know, really enjoyed the slides. One thing I would add that I've encountered that helps when I've encountered resistance is, you know, when we're doing this harm reduction, we're making connections with people, whether it's needle exchange, fentanyl strips, Narcan, you create a connection. A lot of communities are using peers more and more to have those people with lived experience, like Brandy was talking about, be able to connect with people and relate to people. And so then when they are ready to get more help or to get some kind of treatment, they're much more likely to do so. And there are studies out there, I don't have the sites with them, that show that people who have those interactions and connections with people engaged in harm reduction are more likely to get to treatment and or more likely to get into some pathway of recovery. So I think it's important to
that's real important. Yeah. Yeah. At one of the methadone or needle exchange, medically monitored programs that I heard about, they had medical care. It was a needle exchange but it was medically monitored, where people came to use in a safe, healthy environment, a medically stable environment, so that if somebody got into trouble, there was somebody right there to help them. And I think that that model respects it respects the person, and I think that that's more consistent with most of the tribal communities that I have worked with. All have that value of respecting the person and not rejecting a member. And I think that sometimes that you have to remind our tribal leaders that it's not part of our culture and our value system to ignore someone who is suffering. And I think that's a universal value across tribal communities, from my experience.
Sean also mentioned it in terms of the medicine issue, that sometimes it helps to research the medication that you're giving and find out what what elements are actually in that medication, because then you can see that some of it may have come from traditional indigenous medicines, which can be helpful in convincing tribal members to accept the concept of that. And Brandy mentioned that her TOR program actually helps families not give up on their family members, which I think is absolutely fantastic.
I would venture to say it's essential. You know, when you have a family member, even just one, engaged in trying to help the person suffering, it makes a huge difference when it comes to long-term engagement in care. And the other thing I mentioned, I got lost in my thoughts, but I was kind of piggybacking off of what Paul said. When you have the medically supervised needle exchange programs, sites where people go in and use, and if they get into trouble, there's medical care there. It was the statistics was 30% of those who go. Now 30% statistically is a pretty high percentage. 30% of those who engage in the activity end up going into treatment and stopping their use. 30%, 1/3. So that's pretty impressive when you think about it.
Yeah, another quick anecdote that I heard about safe consumption sites, harm reduction in general. If you encounter that resistance, you can say, "Hey, do you have a bar in your community?" And they say yes. It's like, well, those are safe consumption sites. People are prevented from drinking and driving. People are prevented from being overserved. So that tends to make people think.
Yes, absolutely. And I'm going to share another book because Brandy's bringing up family, which is super, super important. And there's a book written by Dr. What is his name? Jay Roberts, that uses motivational interviewing to help family members talk to their loved ones, to reduce shame, to help them understand that the person isn't intentionally trying to hurt them. And it's called Getting Your Loved One Sober. So I might have you also, if you're a family member or you're a tribal leader, and maybe that could be a suggestion, is to raise awareness for them to understand how to handle somebody who's in the throes of their struggles with addiction. So getting your loved one sober. It's a non-shaming, supportive way of working with somebody. Boy, Meg, you're right on it. Did you just find it for us?
I did.
Yay. Okay. Thank you for that. Yeah, but check that book out, especially if you are working with family members, or dare I say, you are a family member who is experiencing that right now. This book can be very, very helpful.
We have about 10 minutes before we were planning to take a break. If there aren't any other questions, perhaps you'd like to talk about what you'd like to do after the break.
Okay. Yeah, we looked at your registration, and we noticed that the people who signed up officially were very interested in just talking to each other and learning from each other how their TOR grant funds are being used, like just kind of what Brandy was talking about there. So we thought that during the break, if you would just take a moment and think about what your role is in your grant and what you see from your perspective is working. If you could identify maybe one or two, no more than 3 goals where you see some progress, or you feel like you've accomplished something meaningful that you think might be a stick around long term. So and then we'll break up into smaller groups, and then we're just going to ask people to go ahead, and we'll just kind of in the small groups go around and just ask people to share their thoughts about that. So that's what we thought that would meet the goals of those who signed up and made comments on the registration form. Now, did that make any sense? Somebody will have to tell me, because
It made sense to me, but I've heard it before.
you have heard it. Bye, Sean. Sean, I need to talk to you sometime soon. So
If I would like to make a different announcement, and we know that some people aren't able to join us again after the break. And I am going to put the link to our GIPRA survey in the chat. If you would take a couple of moments to fill that out before you go, that would be fabulous. For those who are coming back, we should reconvene at 20 minutes to the hour. Does that sound good? And as Kathy mentioned, we'll be breaking into groups depending on how large our audience is, and sharing some of the successes that you feel you've had within your programs.
and just, yeah, even if you don't feel like you've reached the maximum, just a check-in, and just share enough details so people can learn from each other, because that's really what you wanted to get out of today's session. So I just want to say thank you for your participation during our time presenting the harm reduction piece, and we appreciate your involvement and your feedback and your perspective. If you do have to go, thank you for being here.
All right.
Okay.
See everyone in 15 minutes.
Yeah. Bye-bye.
Why that's good. So I just want to make sure, I ask the question and see if anybody have any knowledge of what's, is it there, or what can we do or not do? I hope that clear, the question is clear to everyone.
So how to spend some of that grant money to provide fringe benefits for employees of the grant?
I think what he's asking is,
Okay.
we're told that we have to have an IDC rate and a fringe benefit rate, and we didn't.
Okay.
Yeah, because because on ours right now, like I said, whatever approved IDC, that's the IDC we use, when we send out, for the notice of award. And then when all that comes, you base on that. But, with all the different rules and new things that comes out from the finance side, you guys know that, it's kind of looking at it, say, okay, where we going at with this and what we need to do. So I just put it out there. I mean, we know.
I would suggest if Brittany or Paul are not ready to answer that question, that you talk to Will, who I think is your GPO, to get that answer.
So for that question, actually, I wouldn't talk to either one of us about that.
Oh.
Grants management specialist, we do not deal with the financial piece. So
Okay.
if you change your indirect cost rate, you can start off with 1 and that could change. And if you have any concerns about that, that's something you want to talk with your GMS about, the grants management specialist, which I believe that should be Miss Olivia Klein-Thomas. So you can have a call with Will and Olivia Klein-Thomas on that call, or email both of them directly to get that question answered. And then usually what we would do is have you, I know originally you had to submit an indirect cost rate and ERA, and then if that changes, you'll probably have to submit a new indirect cost rate form with those changes to show before till now in ERA. But that's a question for Olivia.
Okay, good.
Thanks.
That's what I've seen in ERA, and that indirect cost rate being factored into different expenditures on the grant. But Brittany's exactly right. If you have any specific questions, you should talk to the grants management staff.
The summary of our conversation was we started talking about horses and ended up talking about grant goals and money. So, but it was a productive conversation because I think some people got their needs met regardless of the topic. And that's just to help us move along, because I do know that that Brittany, and I don't know if Paul, but Brittany and or Paul are ready to do their thing because they have some information they want to share. So to kind of wrap that up, thanks for your time in the small groups, and thanks for your time earlier. And I think on our agenda, we're ready to go to Brittany. Is that right?
Correct.
Meg? Yeah.
Yes,
Okay.
correct.
All right.
Okay, well, I will share my screen. Give me 1 second. Can you guys see that okay? In presenter mode, can you see it?
Yes.
Okay, great. Well, good afternoon, everybody. I'm Brittany Barber Alexander. I'm one of the TOR GPOs here with the Office of Tribal Affairs. And just want to give you guys some updates from TOR. So the Tribal Opiate Response Grant, the new Notice of Award, Funding Award, has opened. If you haven't already seen some of the emails that have come out about it, or looked online. So the TOR NOFO, which is the Notice of Funding Opportunity, was posted on April 27th, 2022, and will be posted for 60 days. The application deadline is June 27th, 2022. If you applied for the TOR 2021 grant, you're not eligible for this new TOR NOFO 2022 unless you are part of a consortium, meaning a group that applies for multiple grants at one time on the behalf of multiple tribes. So if you're not part of that, then you cannot apply for this grant. Please read and review the new NOFO and reach out to your GPO if you have any questions or concerns about it. It is posted, and when we do post this link will lead you directly to it. You'll see some great changes. I think Paul will talk more about some of those changes after my presentation, but one of the biggest changes I will let you know is that everyone will be awarded more funding. I know that we usually award grantees a certain amount of funding based on your tribe size through the Indian Health Service list. But since they have not updated that since 2019, we've kind of changed that around a little bit. So everyone will get more funding. Check out page 78 on the TOR NOFO for more details. Mid-year progress reports. Mid-year progress reports were due by 4/30/2022 unless you were on a no-cost extension. If you guys have not turned that in, please turn that in. Please check in with your GPO. That should have been turned in already. report summarizing activities over the period of September 30th, 2021 to March 31st, 2022. So again, that's just updating anything that you've done with that grant, highs, lows, storms, success stories, any of those things should be kind of documented in that report. Reports can be sent via email if you need to. If you can't upload that in ERA, but please let us know. Grantees should upload completed reports under ERA under the Performance Progress Report 2020 for multi-year and program aggregate reports for funding year 2021. The GIPRA SOAR TOR program instrument. Updated by SAMHSA's SOAR TOR program instrument went into effect on 4/1/2022. It replaces previous 3-question naloxone tools. The training that we had was held on 4/6/2022. Recordings of link will be sent out. I think we have it attached to another part in this webinar. The GIPRA client level data collection. This is a requirement of this grant, especially if you are doing medicated assisted treatment or seeing clients. You must collect GIPRA data. You must do baseline intakes and 6-month follow-ups and discharges. But please enter that information in the SPAR system. 6-month follow-ups and interviews are required for every client, regardless of discharge status. So please upload those things into SPARS. If you're having any SPARS issues, because the SPARS system is not the most friendliest system to use, and I know I get frequently locked out. So please call the SPARS help desk or email them. They're pretty responsive. You do need to log into that account every 30 days or you will get locked out. So please try to check in on at least once a week. I think a good strategy to use is to try to upload data at least once a week, maybe on a Friday or on a Monday, so you can stay logged into the system. Some of the recent and up and coming TOR webinars. So like we just stated that we just had that new TOR NOFO for 2022 just open. So we did have a webinar for that. So the link's posted here. Also, we did have on May 5th, the 988 presentation and listening session that's pending being posted online. Once it is, we'll upload that link here. March 24th, we had the Using TOR Funding to Improve Data Collection. You can also click on the links here. February 23rd, harm reduction in Native communities. And January 26th, we had a great fentanyl and harm reduction webinar. So please go back and look at any of these if you missed any of them. TOR grant conference calls. So everybody on this call is assigned a GPO. Please make sure that you're meeting with your GPO at least once a month. We want to go over your grant activities. If you're having any questions or concerns, your spending, making sure that you're spending down on your funds in the appropriate time and on the right things. GIPRA data collections and ERA submissions and deadlines, or any issues you may be having. Don't hesitate to reach out to us, even if it's in between a call or you need a call scheduled sooner. Don't hesitate to email or call us. And these are our contact information. So don't hesitate to reach out. And that's it for me. You guys have any questions for me before I turn things over to Paul? Please ask them now, or let me look in the chat to see if anyone had a question. Don't see any at the moment. But if anyone does have a question, feel free to unmute yourself. If there's no questions, then I will turn it over to Paul and let him speak and look for your emails.
Thanks, Brittany. Yeah, I just want to take there's like a minute to, urge everyone eligible to take a look at the new TOR NOFO if you haven't already. And, the main areas we've changed, some of the major changes, like Brittany said, obviously more money, which is good. We got $5 million more overall. And, a lot of things that are allowable now under TOR, we've kind of spelled out and expanded, particularly given the topic today, one being harm reduction and the other being recovery supports. So in the area of harm reduction, funding Narcan, fentanyl testing strips, any kind of public awareness, education, campaign efforts, community outreach around harm reduction can all be funded. We can't the only limitation really is you can't buy syringes, but you can support any other activity around a syringe exchange program. And in the area of recovery supports, we talk. It's not everything is spelled out, but we spelled out a lot more than has previously been listed. So obviously, recovery housing, recovery. Any kind of recovery support, transportation, education, job training, childcare. Let's see, what else? Peers is a big area that intersects a lot of topics, including harm reduction. So I've had a lot of discussions with grantees recently about, hey, have you looked at developing a peer network? You can hire, most of know people in your communities that are, many are in recovery, passionate about recovery, very good at sharing their stories and helping others. With the TOR dollars, you can use TOR dollars to train them and go through whatever kind of state certification you have to become a peer recovery specialist. Usually it's some type of classwork, a couple weeks, however number of hours, usually 500 hours of paid or unpaid training. So you could actually bring someone on and pay them to get their hour requirements, use TOR dollars for that, and then use TOR dollars to hire them on full time and have them start a great career and have them be an asset to your organization. So those are just, and with housing, it could be paying bed fees, or any kind of other costs related to housing, even rehabbing housing and improving housing, developing more recovery housing, sober living. So yeah, this grant is very expansive. I can tell you, someone who's worked with local governments for many years before coming here, you can do just about anything with this grant. It's very flexible. The needs of your community. The good thing about this grant is that you can use it just about anywhere you want. You can use as much of it over here in prevention or treatment, or over here in recovery or harm reduction. It's completely up to you based on, fulfilling the needs that you have in your community. So just wanted to make my pitch for applying for TOR 22 if you can.
Hey, Paul, so I just pulled up the TOR NOFO that's up. So I just wanted to highlight what you were discussing right here. They specifically stated those things he's just saying. I don't think they ever did that in the previous TOR grants.
Nope.
It's actually spelled out in this grant. Now I'd like to point out one other thing, like I stated a little bit earlier, which was on, I want to say page 78, which is the amount of notice of awards as far as funding goes. You should definitely take a deeper dive into this as you're starting your planning. Oh, I can't see it one in this mode, but definitely go back and look at the funding. Hold on, I can pull it up. 1 second, I'm gonna share my screen again. This IHS user population chart is what's really different than any other TOR grant. We've increased each funding year amounts before from 1 to 5,000 folks per tribe. It used to be 125, and as you can see now it's 250. That's per year. So if a tribe size is between this number, that means they get 500K for a 2-year grant. That's significant. So definitely take a look at this, and there's definitely more money to be stretched out amongst your grant to cover more treatment, more recovery, or more medicated assistant options for you. That's it for me. And if you have any questions for me or Paul, please, again, unmute yourself or ask a question in the chat. We're happy to answer.
Paul and Brittany, there is a question that we often get when we're talking about, sorry, I didn't have my mic up to my mouth. When we're talking about allowable expenses under the TOR grant, and that is whether the grantees can use TOR funds for cultural activities. And I remember there was some confusion about whether they could use TOR funds to purchase food for a community picnic, which as the tribes start opening up again after COVID, I'm sure that will become a question because they'll want to get back into the community activities.
Food has never been an allowable purchase under TOR.
Okay.
If you're
What
doing
about other cultural
cultural-
type?
culture related activities? I think we've even had webinars that are posted already online about this that we've had prior to, I think you joining us, that we've discussed this before. But yes, food costs are not associated with TOR. We accept culture related activities. We do approve that, that's fine. And if you're doing events that have a need for food to be purchased, depending on the way you describe the event that you're having and what it's in reference to, if it's prevention, treatment, or recovery, where you're having the event and you are presenting something or having a Narcan training or something like that, there's ways that that could be allowable for a one-time event only, but it's not just, we can allow you to pay for food for the event. That's not allowable. It's never been allowable and it just won't be.
Thank you.
The cultural related activities we definitely support, but you still have to make sure it goes back to prevention, treatment, and recovery. Those are the main reasons this grant is in existence. So you have to make sure that you add the cultural piece around those three things. Otherwise, that's just a cultural event and has nothing to do with TOR.
Yeah, we certainly support that and encourage that. But like Brittany said, as long as it's integrated with some aspect of education or prevention, something related to addressing SUD.
I would like to say too, especially since the weather is changing and things are starting to get better and some of the COVID restrictions are lifting, this is the time to consider some of those things. If you can have some cultural related event and add some prevention to it or advertisement of your program to it, this is a good time to perhaps put on a program like that. I know a lot of grantees are having trouble spending down their funds before this grant ends. This would be a great opportunity to plan something for June or July so you can spend down your funds. And just vet it by us, just talk about what you plan to do. And if we can make it allowable and you still have funds in your certain line items on your grant, then that should be an allowable thing depending on how you choose to go about it. But it can be done. It definitely can be done if you have the right team and plan it out.
I don't see a lot of questions in the chat. And one going, gone. Any questions that you want to get answered? Now's the time. And of course, you can always contact your designated GPO to get some of these questions as a follow-up. All right.
One last thing.
Yeah.
Just because it was brought up in my group, just in case any other grantee on this call is bringing it up. We weren't going to talk about it today, but if you think that you are not able to spend down your funds between now and September, please contact your GPO and consider looking at the rules in order to apply for a no-cost extension. We're a little early. That's why we're not talking about it, but you have until July 29th to apply for one. But you need to apply in July.
Right, a reminder. Especially, important because our meetings get canceled in July out of respect for powwows and summer activities. So we'll remind you next time about it, next month about it as well. Okay. Anything else? Meg, how we doing?
We are about to give everyone almost 20 minutes of their day back.
A whole 20 minutes. Spend it well.
And in return, I am asking that you take a few moments to fill out our GIPRA survey. And I'm putting the link in the chat. You'll also receive your usual follow-up email when we have the recording and the slides available. Roxanne, working with the St. Croix tribe in Wisconsin as a peer recovery support specialist. That's awesome, Roxanne.
Mhm.
I'm so glad you're here today. Thank you for joining us.
Meg, I have a question.
Yes, sir.
Yes.
Can you hear me? Okay.
Yes.
A lot of times during the summer, there's a variety of events such as powwows, basketball camps, all kinds of outside activities, cultural immersion camps. And many times they're sponsored by multiple organizations and or funding sources. Or being involved with agencies that all kind of chip in towards certain things, we ask that certain things we be allowed to speak in regard to prevention or whatever it might be, that our tables that are there have the material necessary to talk about TOR, and whether it's prevention, intervention, whatever it might be. Does that complicate things a bit in regard to multiple funding sources as not being just a TOR activity?
Paul or Brittany, probably better qualified to answer that than I am.
Yeah, I think you would have to, be clear on what you're using the TOR money for. I guess you're talking about where maybe multiple funding sources go kind of into a pool to fund a variety of activities.
Yeah.
Mm-hmm.
Yeah, I think it still goes back down to, for TOR, it has to be TOR specific. So whatever event that you're planning or going to use TOR funding for, it still needs to be a part of the scope of whatever your grant is focused on. So if your grant was only in reference to medicated assisted treatment, you can only spend funds that deal with medicated assisted treatment activities. If your grant was in reference to prevention or recovery, then it has to be in reference to that. So other activities would not be allowable.
Yeah, I understand that. It's, for an example would be if we were to put on a immersion camp and half of it was spent by behavioral health and half by TOR on prevention with our targeted clients. And we were able to speak and talk about that issue within the camp. Having two sources of funding, is that a problem, or does it ultimately have to be a complete TOR event?
Doesn't have to be a complete event, but where is that coming from in your budget? What line item, and is that something you already planned out?
Yeah, it's in a line item. I just wondered if you could do that with multiple sources.
Yeah, you're free.
Yeah. Yeah, if the overall activity is allowable under your grant and it's being subsidized by another source, there's no problem with that.
No problem. So say if that other grant is allowing you to spend, money to, pay for food and we don't, and you're using summer TOR funds for advertisements or pamphlets or, things for your program, that's allowable. So then yes, you can do it.
Thank you.
Mm-hmm.
We're kind of doing blessings in the chat box while people are talking. So yeah, just offer a blessing to all of you for all the work you do. Sometimes it's you work and work and work and nobody notices, but I just want you to know that we notice you and we applaud you and we feel grateful that you're there working to help our people recover. And congrats to Roxanne for your recovery. And I can hardly wait to hear what your stories will be. I'm sure you'll have plenty to share with people. It's a blessing to have you here. Have a good rest of your day, everybody.
Bye.
See you
Thank
later.
you.
Thanks,
Bye.
Brittany and Paul, for answering all those questions. That's great information. Thanks for that.
No problem. Don't hesitate to reach out.
Yeah.
All right, thank you.
Okay. We'll see you next time, everybody.
Thank you.
Bye-bye.